So David, we've been here before. Gordon Brown authored a conversation in which he dispatched his ministers and MPs all around the country to find out what people wanted. And now you want to do the whole thing all over again.
At that time, as you remember, the NHS was getting 8, 9, 10% growth every year. And the world was a very different place for the NHS. We're now looking forward after 3 or 4 years of almost no growth to a position where that's probably going to be the case for the next 5, 6, 7 years.
But you want a conversation in which you know a great number of the answers, and many of the people you want the conversation with genuinely don't know the answers. And surely your job is to say, look, this is what we have to do, and we want to get you behind us. You can, for example, deal with the problem in which we have to look after 25% of the population who can't look after themselves, the elderly, the infirm, whoever they are, and they need special provision. With your help, we could provide that provision, but the trade-off is you have to lose some of the things that you don't actually need, like the local hospital.
Part of the issue is that there is not a common understanding across the population, the NHS and the public about what the real challenges are and what they actually mean in practice. So we've got the demographic changes that you described, we've got the expectations of our patients, we've got medical technology, we've got the ambitions of our clinical staff, all of those. And what we've tried to do is put a monetary value to focus people's attention. That's about a £30 billion challenge over the next 5 years for the NHS. And we need that common understanding, because we need everybody in the system to start to engage in the real choices that come out of that.
But surely if you don't tell people the brutal truth, the politicians will get in the way. The politicians will come forward and say, I'm sorry, you cannot shut that local provision. What you then need is for the population to say, we need to shut that local provision because we need elderly care.
We have to have that conversation. We can't shortcut it. But some of those big changes do need political buy-in.
They also need charismatic salesmanship, charismatic leadership. And that isn't surely what your team any longer has.
Well, most of the change that you're talking about is done at a local level, and it's clinical leadership that you need in those circumstances.
Yeah, but you want to lead a conversation which starts at the centre, and you're the leader of it.
It doesn't
do people have confidence in you?
It absolutely doesn't start at the centre. It starts at a local level. And what they need are clinical leaders who understand the scale and nature of the change, who can talk to their local populations about it.
But you're the strategic power. You have the capacity to say, we are going to devote 30 billion to actually providing this country with the kind of elderly care. I've gone on that because that is your biggest crisis point, that the NHS is sinking beneath a load of care for geriatric patients.
I don't quite accept that your premise about the NHS sinking under care for older people.
Well, it's 25% of what you do.
Older people. There is fantastic care given to older people across the NHS.
Now, it's easy to blame the media, and the media have some responsibility for this. The NHS is a brilliant service, and it's the envy of many other countries. But the fact is, it also has serious problems that undermine its credibility and undermine people's confidence in it. And part of that surely is you.
I think inevitably in the circumstances, if you think about the NHS, and the example I would give you is that we have the lowest hospital mortality we've ever had since records began. So things are dramatically improving. And at the same time, sometimes really bad things happen to patients. Now you have to have a conversation which holds both of those things together. Yeah, but if you get into one, you end up, if you get into the first one, you get into lines to take and aren't we wonderful in a sort of strange way, or the other way, you kind of completely demoralise all of our people.
Yeah, but the problem is people don't believe that these patches of bad activity in the NHS, mid-staffs, the Furness Hospital, that they were badly handled, and that they exposed the reality that, for example, we have the CQC, which is a completely unmanageable beast, and which surely you as Chief Executive of the NHS should have spotted is simply unmanageable.
There's no doubt. If you look at if you look at the Francis report and all that, you can see that what was created during that period is a set of organisations which didn't share information, were not open with each other.
But as Chief Executive of the NHS, you must have spotted that. You must
deliver
have
the
spotted
services.
that.
We had to have a public inquiry to get into the detail of all of that.
Why didn't you say to your ministers that the CQC is a ridiculous concept? 41,000 institutions to be inspected and a cut in their budget. You as Chief Executive of the NHS knew better than anybody that this was not a goer.
CQC,
True or false?
Well, CQC was always having a really difficult job. It was announced, as you know, by politicians. It was announced as
but you could have told those politicians, I'm sorry, as Chief Executive of the NHS, I don't want to be on deck with a thing like that. Couldn't you have said that? And my goodness, if you'd threatened that, they wouldn't have liked that at all. And they probably wouldn't have gone that route. You're in a very powerful position.
I think that this is another conversation about what I thought or didn't think about CQC. But the important thing is...
Well, it's important people know.
The important thing is we have a leadership of CQC now which is dedicated to putting it right. And
yeah,
that's the critical...
It's still a ludicrous idea. It's still a ludicrous idea that one institution can look after the care involving 41,000 institutions. So far, they've shut down 2 elderly care provisions. Well, that's nonsense.
Well, regulation can never do that. This is part of the issue that I would say about the false assurance sometimes people get from regulation.
Whilst the patient is aware of these things, you want to have a conversation with the patient, and the patient doesn't have confidence in the institution that you lead and your leadership.
The point I would make about all of this is that the danger we face at the moment is we sleepwalk into a place where quality is really threatened for the whole of the NHS. And what we want to do is have a conversation with people about what are the alternatives, what are the tough choices that you've identified already in terms of elderly care that people have to make.
And what reassurance can you give that whistleblowing, in other words, telling the truth about what's going on within the health service, is going to be encouraged rather than shut down as it has been on your watch? It's been on your watch that this awful culture of telling people they may never speak and even paying them not to speak has occurred.
Yeah, there's been a lot of debate about all of this. We have the biggest staff survey in the world. 160,000 of our staff are involved in that. We've been tracking this for many years. The position in the NHS has improved over the last few years into people feeling that they can speak out. It's vitally important.
But you've still paid people in the last 2 or 3 years not to speak out.
It's vitally important that they do speak out. When you're going through any kind of change, it's critical that people are able to speak out. And wherever I've found this, wherever I've been engaged in that, I've encouraged and supported people to do that. And we've given them all the support that they need, in the sense of we made it very clear that it is illegal for people to put gagging clauses on people to stop them speaking about patient safety. And we've done lots of things with professional organisations to support and help that.
But your centre has had to
forward.
sign off on people being paid not to speak.
Compromise agreements is what you're talking about now, which is about, they're widely used in health.
Well, I call that gagging.
But also
compromising clauses, that's gagging.
But see, one of the things about all of this is that when you look at the cases individually, these are often very complicated cases where individuals have not only fallen out with their employer or have lost confidence with their employer, but also have lost confidence with their colleagues. And so there are many reasons why, in those circumstances, confidentiality is important. The key for us is to make sure that confidentiality is never used to protect problems in patient safety, and never used to make sure that people don't see that if poor practice or misdemeanours have happened, are not come out to the public. And that's exactly what we've been doing over the last few years.
Sir David Nicholson, thank you very much indeed for talking to us.
Thank you.